Right, perfect, Mohit. That's going live now. I will start the webinar now.
Thank you. Brilliant. So, colleagues, give us a couple of ticks as many of you stream into the webinar. And the wonderful colleagues in the background are helping it make happen seamlessly. And then we'll give a start. So just give us a couple of ticks. Right. You can see we've started having a fair few come in already. Let's give a start to this. In the last week or so, we have been inundated by the fact that we should be expecting a storm. And there's showers, and there is this chilling, spine-chilling cold that's been going on. And despite this really adverse weather, snow up north, showers everywhere, mucky, there is one part of the sector that continues to work like a well-oiled machine. And it continues to serve us as we want it to. That's the health service. So, do I think there is an opportunity to still improve further? Of course there is. 100%. There are so many things we can get even better than we are getting now. Do I think there are issues to fix? Without a doubt. There is so much more that can be done. But despite those views, there is no doubt some of the most amazing staff on a daily basis provide care to so many of us seamlessly. My mum is 80 and she has a long-term condition. I accompany her very often to the hospital so that I can get her tests and speak to the consultants, speak to the nurses, the specialist nurses, amazing group of people. This Friday, she has an appointment for her scans and I can't get out of work. There is absolutely no way. So I had the pleasure of speaking to the patient transport services. And this absolutely lovely lady picked up the phone. She helped me navigate through a system I have never used, which many of our colleagues do. She made sure it was all arranged exactly as needed. And today morning, I got a call reconfirming everything was arranged and it'll be done. Now, we have often spoken on these webinars about the fantastic clinical services that so many of our clinicians provide. And we celebrate that outstanding clinical care. But the reality is that the health service has the most amazing, experienced support from staff, both from the clinical training end and the non-clinical end. Staff who are on reception services, staff who are on transport services, staff who work as porters, staff who work as cleaners, but who on a daily basis keep the machinery working like clockwork. And it's that dedication, that drive that makes such a difference to the clinical care clinicians provide on a daily basis. Now, colleagues, good evening. My name is Mohit Venkatram. I am a doctor by background, and I am the host for the Future of Primary Care webinar series. I've been a host for the last 4 years, and I have had the joy and privilege of working in primary care for the last 20 odd years of my life. Very early in the system, I recognized that primary care is very, very rich in passion from the clinical staff and the non-clinical staff. It's very rich in clinical expertise from many of the colleagues who work there. But where primary care was more challenged was in having good corporate support. And that's where I decided to create this webinar so we had an opportunity to share the best practice. I spend a lot of my personal time creating the webinar, but then you need additional support for the infrastructure. And that's where a trust like Northeast London Foundation Trust, where I have the privilege of working, stepped in. Because at Northeast London Foundation Trust, there is a strong belief that to serve the 4.3 million residents, the only way we can do it well is if we do it along with our amazing primary care colleagues. Because together, in the boroughs we serve, Barking and Dagenham, Havering, Redbridge, Waltham Forest, and many parts of Essex, it is the passion of those GPs, passion of staff who work in primary care, who together allow us to provide a very different environment out of hospital that's safe, effective, and cares for our residents. So, for colleagues who have joined me over this journey over the last 4 years, you will always be aware we spend a couple of minutes reflecting on the fabulous delivery of primary care over the last reporting period. The last reporting period of December 2025, so that's just short of 6 weeks back, is available. And I spent some time today looking at the calendar to count the number of actual working days in the month of December. We know, colleagues, it's a month full of bank holidays, it's a month full of holidays. So things start turning off. December has 21 working days this year, and I counted them out. Can anyone guess how many appointments primary care delivered in a month with only 21 days? Drum rolls. 32 million appointments were delivered by primary care in the month of December alone with only 21 working days. Now, many people talk about the fact that, yes, they may have delivered that, but how many of them were same-day appointments? So if I have need now, was it given to me today, or did I have to wait 5 days? 46% of appointments were same-day appointments. So we're talking near about 14 million appointments were same-day appointments. 14 million people picked up the phone that morning to say, I want to see my GP or my nurse, and got an appointment. 90% of us attended our appointments. So unfortunately, we lost about 3.2 million appointments, which we could have made use of. And 60% of these appointments were face-to-face. So if people wanted to see the doctor or nurse or therapist or podiatrist or anyone working in the primary care arena, they could do it face-to-face if they wanted. And for those of me who work, I love my remote appointments. You got that choice too. Now, what does that actually mean in numbers? On a daily basis, primary care was delivering 1.5 million appointments on a daily basis. More than half the residents who live in this country were able to access primary care. That's the number of appointments primary care delivered. So 1 in every 2 of us. Today in this webinar, there are slightly over 200 people registered. That means almost 100 of us of the 200 access primary care. The question then that arises is, given the magnitude of work that happens in primary care, is there actual time for the clinicians, for the clinical teams, to focus on what matters to us? Or was all the time spent in dealing with the disease condition? Hypertension, you've got diabetes, your blood pressure is high, here's the medicine, go on with it. But actually, the difference in primary care is that unlike acute services in the hospital, the opportunity to support us, to change our habits, to support us recognize what lifestyle changes make a difference is so much more. So was that happening? Were we able to form a bridge with the communities? And were they able to find in-reach into those communities through health events? Many GPs have done some amazing work. Many nurses have done some amazing work. But one such name who has not just done this amazing work, but has been recognized nationally by the Health Service Journal Awards is Dr. Camille Hirons. Dr. Hirons is one of those fabulous leaders who has bowled me over when I spoke to her. She is the clinical lead for Southeast London ICB and the Cancer Alliance. She is also one of the very, very passionate advocates of lifestyle medicine, which we will have the joy of hearing in another webinar. She is also the Health Equity Fellow for her primary care network. And I have such pleasure in speaking to Dr. Hiron, because when I spoke to her, you walk away from some conversations which demonstrates someone's personal passion and zeal, and it shines through in a way that it bowls you over. That's how I felt when I spoke to her. So today, I am really looking forward to us having an absolutely amazing time hearing about the work on health inequalities that her leadership has changed and delivered. But before I do hand over to her colleagues, a reminder. There are 200 of us who have registered today on this webinar, and there are multiple platforms people are on. If you want to post a question, please use the Zoom Q&A button to post your question. I will pick out the theme from the question and then present it to Dr. Camille when she's had the opportunity to share her thoughts with us. Camille, it is such a pleasure to have you on the webinar today, and thank you for giving us the time. Shall I hand over to you?
Absolutely. Gosh, thank you very much, Mohit. That was a very generous introduction. Hopefully I don't let you all down. It's a real pleasure to be here today. I love absolutely any excuse to talk about health inequalities or lifestyle medicine. So thank you very much. As Mohit has said, I am called Cami. I am a NHS GP, and he's already mentioned some of the roles and the hats that I wear. But my two main areas of passion and focus are health inequalities and lifestyle medicine. So today I'm going to tell you a bit of the background to our health inequalities work that we have going on in Lewisham. I'm going to tell you about our health equity programme, and then I'm going to tell you more about the delivery, the outcomes, our conclusions, and then hopefully a really interesting opportunity to hand over to the Q&A and hear from all of you, because there's lots and lots of pockets of absolutely excellent work going on. So this, may just be a refresher for all of us, but what are health inequalities? Well, health inequalities are systemic, they're avoidable, they're unjust, and they're unfair. And they're deeply linked to socioeconomic factors. So what does that mean? That means that poorer individuals are more likely to live shorter lives and suffer more ill health than their wealthier counterparts. So the social determinants of health, I'm sure you're all aware, sometimes called the wider determinants of health, they are the diagram that you can see on the screen. Those are essentially the conditions in which we are born, we grow, we age, we live, we work, and eventually we die in, and a lot of them are deeply out of our control. Now, we can't really talk about health inequalities without mentioning Sir Michael Marmot and his review, and I'm sure that a lot of you are already familiar with this. For anyone who isn't, this was a national review that was led by Sir Michael Marmot, looking nationally at what we needed to do within our health system to try and tackle health inequalities. And there were some really tangible and actionable outcomes that were recommended, or actions. So, for example, to act on the social determinants of health that you can see on the screen, to try and focus in the health system on prevention and early intervention, to adopt proportional universalism, and I will touch quickly on what that means in a second, to integrate care, and also to strengthen public health systems. So then there was the 10-year review, also led by Sir Michael Marmot and his team, to see how well we had got on nationally with his recommendations. And spoiler alert for anyone who isn't aware, we have not done very well. We essentially neglected to act on any of the recommendations that were in the report. And for the first time, life expectancy had stagnated nationally and even declined in some areas of most deprivation. So it was a real stark realization. Now, I work in South East London, and it's an incredibly diverse and vibrant and exciting place to work and live as well. But we really have to recognise the ethnic health inequalities that we are faced with, some of which we'll be much more aware of. For example, Black women are more likely, by 4 times more likely, to die in pregnancy or childbirth than their white counterparts. Some of them we are less aware of. They're on the screen there as well. But we also, I think, as a health system, have to start to understand the interplay of discrimination and stigma, institutional racism and structural racism on our overall system, and the effect that they also have on those wider and social determinants of health. So just a bit more background, the Core 20 Plus. I always feel everyone has heard of the Core 20 Plus, but I was giving a talk the other day and only one person put their hand up in the room to say they'd heard of it. So I thought I would just give a quick refresher. This is another way of trying to identify individuals and communities who may be at risk of health inequalities. So the Core 20 refers to the 20% of the national population who are the most deprived, and that's as per the Index of Multiple Deprivation. And then the plus refers to these 2 groups. We have the disadvantaged groups. These are people who are disadvantaged due to things such as ethnicity, where they live, maybe their age. And then we have inclusion health groups. So those are people who are vulnerable by nature. They may be experiencing homelessness, maybe they are asylum seekers and migrants, people with learning disabilities, and so on. So that's the Core 20 Plus, and then the 5 refer to the 5 clinical conditions you can see across the bottom of the screen, and how, as a health system, again, we should be targeting these 5 clinical areas to have the biggest impact on health inequalities. So very quickly, I just wanted to touch on the difference between equality and equity, because this is that piece on universal proportionalism that Sir Michael Marmot mentioned in his review. So we're very good in the health system at equality. We give all patients the same amount of appointments, the same length of appointment time, the same medications, and so on. But actually, an equitable approach is giving more resource to those that need it the most. What we're doing is leveling out that playing field with regards to health outcomes. So the diagram on the screen, if we give everyone the same size box, only one person can reach that fruit off the tree. Whereas with an equitable approach, everyone can then reach the fruit off the tree. So I'm going to get a bit more stuck into what I've done and why I'm here. But to do that, you really have to understand Lewisham, the area in which I work in South East London. So I've already mentioned how South East London is vibrant and diverse, and Lewisham is definitely that. We have a population of around 300,000 people. Now, remember that Core 20 Plus that I mentioned, 67% of our population fall within the Core 20 Plus, just to try and illustrate how many people are at risk of health inequalities locally. And with that, half of our patients don't speak English as a first language, so we have many other barriers as well. We have up to an 11-year gap in life expectancy between the most and the least deprived. We have a housing crisis, with the Lewisham Council referring themselves to the Housing Ombudsman because they're in such a terrible state. Around 7,000 families waiting for temporary accommodation. We also have a large population of people experiencing homelessness. And we also house an asylum seeker accommodation, an initial accommodation centre. So just to give you a bit of background, there are, of course, lots of pockets of wealth, but there are some real pockets of deprivation and a lot of poor health outcomes within our borough. Now, health inequalities in Lewisham have been really informed by an absolutely incredible review that I urge you all to take a look at. It's called the Birmingham and Lewisham African Caribbean Health Inequalities Review, which is a long name, so they've ended up calling it BLISHEAR. Now, the reason that Lewisham and Birmingham City Council have paired together is because they actually have quite similar demographics, with a very large population of Black African and Black Caribbean patients. And they co-designed this report and this review that looked at what we needed to do locally to try and address health inequalities. And these are the health inequalities specifically faced by these Black, African and Caribbean communities. Now, what we know is that there are layers of disadvantage for our Black population in Lewisham, and there's widespread inequities in socioeconomic and environmental factors as well. And those are the kinds of things that create barriers to healthy behaviours and also health access. So there were some really clear messages that came through the report, things that we needed to do to address the root cause of some of the issues. And a lot of those align with those social and wider determinants of health. And they had some key recommendations as well, some of which, as you can see in a moment when I move on, we tried to do within our project, things like health checks and campaigns, healthier behaviours and health literacy as well. So that is the background really to what I'm here to really talk about, which is the health equity programme that we have in Lewisham. So in order to try and address some of the outcomes and some of the actions in the report from the Blaschere review, our health equity programme was essentially born. Now, it was led and driven by Dr Amina Verity, and that was based on some of the work that she had done in North Lewisham Primary Care Network. And it was thought, actually, if we incentivise and pay for a GP's time to really spend their time looking at health inequalities, and do that with a community organisation, that could really have wonderful effects on the whole borough. So the model essentially brings together these two groups, a community-based organisation and primary care, to work in partnership. A better way of showing that is that Public Health have been funding this project. The Health Equity Community of Practice Lead for the borough is Dr Amina Verity. And then in every primary care network, and at the time that I was doing this, there were 6 primary care networks. There is a GP Health Equity Fellow. I was the GP Fellow for North Lewisham. And there was a community-based organisation. We were paired together, and I'm going to tell you more about what we did. So our community-based organisation was Red Ribbon Living Well. They're an amazing community-based organisation who support people who are living with HIV, mental health challenges and domestic violence. And I was the Health Equity Fellow for North Lewisham Primary Care Network. That's the largest PCN within our borough. It is the PCN for 9 GP practices, a population of around 90,000 patients. So it's very big. And together we form the health equity team alongside our community link worker who was hired within our primary care network. And the whole ambition of our project was to co-design something truly co-designed to tackle health inequalities for our local area and our local population. I've already told you a little bit about Lewisham, and that's very much the same for North Lewisham. It has some of the poorest health outcomes actually within the borough of Lewisham in the north, and also in the south of the borough as well. Now, together we found these 3 areas of interest and these 3 work streams that we wanted to work on. We were quite ambitious, I will admit, and these I'm going to talk you through over the next few slides. One is the health equity champion work, the second one is our community health hub work, and the third one is our HIV stigma training. I'm going to start by talking about our HIV stigma training. Now, Red Ribbon Living Well are experts in living with HIV and HIV stigma, and we really wanted to harness that to create some meaningful change locally. So we co-designed a short animation. We used people with lived experience with their real lived experience. And we also co-designed it alongside health professionals. And the aim was to highlight opportunities for better care without blame. We're trying not to blame primary care. We just wanted to highlight some unintentional stigma. So the animation shows a current care scenario, if you like, with real life examples. And then there's this sliding doors moment of what stigma-free care could look like, very, very small changes. And what we did is we delivered this animation to our protected learning time, PLT. There were over 114 primary care staff there, both clinical and non-clinical. And we were able to show improved confidence, awareness and knowledge in HIV stigma. And then what's fabulous is after that, a lot of the practices then signed up to our HIV Confident Charter, which was run by another organisation, but that really supported primary care to be HIV stigma free. So the graph on the left just reinforces what I've said, essentially, that confidence levels were before the training that we did and before we screened the animation. And then the graph on the right shows our post-training scores. And essentially, you can see that the confidence has risen dramatically. And there were around 26 people who didn't feel confident at all. That reduced to 3 after our training. I'm going to move on and talk about our health, equity and wellbeing champions. So this was kind of our initial project, our initial work stream, and it really impacted the rest of our work. So we recruited 20 health, equity and wellbeing champions, and we trained them across multiple different subjects, including some accredited courses, and even some simple things like how to use the iPad that we were using, how to refer into local services. We then used a data-driven population health approach, and we looked at the deprivation mapping in our primary care network to find specific locations that would reach the most underserved individuals and communities in our population. And what our champions did is they regularly, almost every week, went out to these locations and they engaged with people. They spoke to people. They used culturally sensitive, trauma-informed approaches to build trust. And they were also representatives of that community, which I think was just so, so valuable. So our champions raised awareness on issues like blood pressure monitoring, how to get an HIV test, where to get PrEP if that was relevant, even things like cancer prevention, and then some really practical things like how to register with a GP locally, how to navigate the somewhat complex NHS services that we have. Now, our champions also ran a survey, and that was on trust and the barriers to care and access. And what we were able to do is get 140 survey responses, and we did a thematic analysis of that. And from our thematic analysis, we can see that access was the key issue and one of the biggest barriers. And unfortunately, in an ever-increasing digital world, digital booking systems worsen exclusion. So we found that when people that we surveyed could not book a GP appointment, 31% went to A&E and 16% of people saw no one, which is possibly masking some really serious symptoms leading to late diagnoses as well. So, some key recommendations from our survey with some simple results. To simplify booking systems, always have another option, so maybe a vulnerable line for people who are digitally excluded. To support those who are digitally excluded, and to develop outreach and a prevention strategy locally. Now, it's quite a busy slide, but along the bottom, we just wanted to highlight that there were so many unintended positives from our champion work. So I think just building their confidence was the main one. They themselves gained huge knowledge and confidence, and they were able to enrich their ability to support others as well. But we will come back to that in my conclusion shortly. Now, our champion work led us to develop our biggest work stream, which was our community health hubs. This was definitely the largest piece of work that we did. Now, we carefully chose location, again, based on the deprivation data. We have 9 GP practices, so we wanted to create a hub in proximity to all 9 practices to ensure there was an equitable approach as well. We also had a community forum within our primary care network. That's a coming together of community residents and community-based organisations and healthcare stakeholders. So we spoke to them and got their co-design ideas on what we should do, what we should include in these kind of things. So our vision was a one-stop shop for health and well-being. So people could just walk in and get a health check. They could also get community sorry, I've just lost my place. Yeah, one-stop shop. They could walk in and get a health check. They could get additional tests as well, but they could also get follow-up. We didn't just want to do case finding, which is an absolutely excellent and really important piece of work, but we wanted to provide some solutions in the same place as well. This was really, really collaborative, and I'm going to show you a bit more on how it was collaborative shortly. But people would come and they could get a health check in these spaces, the additional tests, the solutions, and then also many activities. So just to show you how collaborative this was, we worked with 16 different community-based organisations who came to all of these events, 10 different NHS services across 3 different NHS trusts. And we all came together each month to provide integrated, free care, case finding and all those solutions and things that I mentioned. You could literally walk in off the street. And we also did a lot of things like batch messaging people who might be due a health check or people who hadn't seen their GP in a certain number of years as well. So there were lots of things that we did to try and get those underserved people through the door. So we did this part of our project for around 12 months, and we were able to engage with 678 people. We delivered 400 health checks across these 9 different health hubs. We also ran a really, really tight agenda of activities because we wanted it to be a fun and a vibrant atmosphere when you walked in. So we had things like Pilates classes, singing, dancing. We had workshops on inequality, cancer prevention, HIV stigma. And it became a very vibrant and also very accessible space. But what about our results? So I've mentioned how many people came, but essentially what I'd like you to take from this slide is that we found much higher prevalence of abnormal results than your standard NHS health check. More people had a higher HbA1c, a raised systolic blood pressure, a raised urine ACR, and a higher BMI than the national average when you're doing a health check. We also utilised something called the EQ5D5L, very catchy name, but it's a validated wellbeing score. And we were able to show that 30% of people that filled in our survey rated it as a poor overall health, and 22% had a poor health-related quality of life. So not only do we know we're reaching underserved populations, but they're not feeling well and they're not feeling happy as well. So some really important results there. Now, with regards to feedback, we did yet another survey. We asked 135 people that came to our hubs what they actually thought about them. So 84% felt satisfied, 88% felt they had their needs met, and 98% would recommend the hubs to family and friends. They thought that they were accessible and they were really comprehensive as well. We also wanted to find out what the staff felt because they kept coming and delivering these slightly chaotic but very exciting hubs. And essentially all of them said that the hubs were effective, they really valued the one-stop shop model, and they would love to have seen them scaled further as well. So our health equity team projects were very ambitious. They were some of the most challenging work that I think both myself and Red Ribbon Living Well have done, but they were incredibly rewarding. So our champions remain really active and they have blossomed so much. It's amazing. Some began the whole project. They were completely hesitant. Some of them had never mentioned their HIV status to anyone. But by the end of our project, they were there and they were proudly sharing their stories and promoting health across communities. And that was an amazing outcome in itself. And since our work, Red Ribbon Living Well have seen an influx of new members, which is amazing as well. We've also informed the next cycle of the health equity team. So I'm really pleased to say that this project of the health equity teams is still running. They have a different focus. There are new teams, but it's so nice to see that they've put money back into this project, which is amazing. We've also shared our HIV animation with many different platforms. It's freely accessible on YouTube. So we have the South East London Forum and the 4M network as well. And that's actually being shown in local GP waiting rooms, which is fantastic. Not only that, but we've built so many partnerships with all that collaboration. We've attracted even more collaboration from other organisations. We've supported other ICBs to set up their own kind of community outreach events as well. Because I think I rushed through, but we had other things like hepatitis C testing, Hep B testing, fibro scanning, STI checks. So it was really comprehensive. We were very, very fortunate. Yes, and so beyond all of that, I think gaining the confidence and the pride in the wider network has been amazing. And as Mohit said, we are very, very proud and very fortunate that we were the winners for the HSJ Award for Primary and Community Care Innovation of the Year. So, although it's just myself presenting today, I think it's really important that you're aware that this was very much a team project and we were in equal partnership. And that's between Red Ribbon Living Well, myself, and Joyce, our community link worker. We worked incredibly hard on the balance of power between our team. And I think that's some of the biggest learning that actually all of the projects had. And we really, really wanted to make sure all of us had a voice within our project. Because we see that all too often, even when we try to collaborate, the balance in the hierarchy can be really, really challenging. So I'm going to stop talking in a second, but I would love to see more integrated, more joined up ways of working. And hopefully, if anything, we've proved that actually incentivizing paying for a clinician's time to work on health inequalities and really, believing in a community organization can really go a long way. So I'd love to see this kind of work and health equity programs being done in other areas as well. So I'm going to stop sharing and hand back over to Mo.
Cami, that is mind-blowing, I was right when I spoke about your passion at the start. Without a doubt, that colors so much, and it gives so much vibrance and life to something, because it could very easily just be a dead project, and it isn't. It's a living, organic thing, and you can feel your passion drive it, and you can hear from the work of the other people who worked in this, Red Ribbon, how they feel about it. Just the very fact has driven up their membership at the end of it. That's what they want to achieve as a community organization. The more the community is engaged, the more you're building solutions that make a difference to people's lives. So it's just fascinating what you spoke about. And there are questions you can imagine, and there are people who had already emailed me the questions too from their perspective. But let me start with the very first one, which almost always hits us in this webinar every time. And I'm surprised no one has put it so far in the chat, because this was emailed to me in advance of this webinar today. Was public health supported to recognize the value of investing in something like this? Because the reality of life is that our local authority partners are even more stretched for resources than we are. So they are under real cosh. They have a statutory responsibility to break even.
Yeah.
Of course, we all have to, but it is written in the statute for them. So it's not easy.
No.
But the fact that they valued this work shows a lot. So what was it? Your passion again?
No, well, I can't take credit for setting up the whole health equity program for sure. I think a couple of things. So it was very much led by Dr. Armina Verity, my colleague and friend, who is equally, if not more, passionate about health inequalities. And it was based on the fact that we had already done work in North Lewisham in that the primary care network that I just happened to be working in. And so she'd set up a community forum that was thriving. We never had any of that. She had paid time and was able to show all the benefits of paying for a clinician's time to work in this area. Because I think you'll find that most clinicians, they know a lot of what they want to do or what would really be a huge impact for their population. But ultimately, the elephant in the room is there's only so much you can do for free in your own time without completely burning out. So I think she was able to demonstrate that she'd used some data. It was very data driven, what she could do with a small amount of time, imagine what we could do and how we could spread this across the 6 PCNs. I also think it was very different when we first started. We weren't initially in the first month meant to be paired with a community organisation. And I think some funding had come through from the council for a separate piece of work around communities. And they thought, hang on, let's do it together, which was an amazing thing that they worked out. So I think it was fortuitous in lots of ways. But I think Armin is quite, persuasive and passionate, which is good to be. So I think a bit of luck and also, a bit of passion and data.
It's quite phenomenal, I think, what's been achieved. And don't get me wrong, these are not programs worth millions. These are programs worth a few 100,000 that's put in.
Yeah.
But what you have delivered as an outcome far outstrips that £1 investment delivers £10 back, because actually what you've done is much more than that, because you've created a generation of difference in all those people being able to access something so different from what they were. And, the part that really got to me was when you said there were colleagues in Red Ribbon who were working there and had never shared how
Mm,
they felt and what their lives were like, and the fact that they were HIV positive
mm,
or were under treatment or were now on treatment, but they were fine. But boosting that confidence
mm.
actually means you bring the person out of that person. You suddenly become your own person. And that confidence counts for a lot more in terms of economic development in the area, the ability to drive change, the ability to stand up and talk about your experiences, making a difference to someone else.
Yeah,
We live in a world where preps and peps make a lot of difference. It's not the same world as it was. But the reality of that is, we talk about preps and peps as though it's easily accessible. It is not.
no.
There are loads of people, even today, who I bump into or I talk to who are positive at the age of 20 and
Mm,
they are not taking any treatment and they're hiding it. And a part of you thinks, gosh, from what it was a few years ago, HIV is it's not a treatable condition, but it's a manageable condition. You can manage it safely
yeah,
and live a fully productive life without any impact whatsoever. And I think that chance is being missed. And what you've done is you've not treated the condition, you've treated the person. They have got a lifetime in front of them, which is phenomenal, phenomenal to hear. I think
thank you.
as my trust, many colleagues who work around in the area often talk about the stigma of mental health.
Hmm.
And you spoke about stigma. And while it was in a physical health condition, there is no long-term condition that does not have psychological impact. There is absolutely none.
No.
Even people with diabetes, now evidence is showing 40% of them need interaction in terms of psychological support merely because of the condition. And I was wondering if you have had any experience or known anyone to have had experience of working with either prison populations
Mm,
or people with mental health conditions, because it's a very similar parlance.
yeah.
And I wondered if you had any thoughts on that, Cami.
I think stigma, as you've said very eloquently, is not just one condition or population specific. We stigmatize almost everything. My biggest bugbear at the moment is weight stigma. And I really think that in health systems, we need to be compassionate with our language. There, in my opinion, isn't much benefit to using words like obese. Even in research, what would happen if we used more compassionate language? Probably nothing, we'd just be a bit nicer. Um, but yes, mental health and prison populations. I have never worked in a prison. I have known a few people who have. We do, in my practice that I worked in as a salaried GP, had quite a few people experiencing homelessness. We also have lots of asylum seekers. We have huge volumes of people with mental health conditions, some of which are severe mental illness. There is a lot of stigma. There's a huge amount of stigma, let alone all those social and wider determinants of health that are also at play. What was the question, Mohit? Sorry, what was it around that?
So the question was, do you draw any parallels between the work you've done
Mm,
on stigma for HIV? Because that's not been the core part, but that's been one of the parts consequent to your partner
yeah.
in that project. How do you draw any parallels between that and the stigma faced by people with mental health conditions
Yes.
and prison populations, because they're quite often related, the forensic part of it, creating a mental health. And do you see there being an opportunity, given your experience of having led something like this, of doing something different?
I always think we can do something different. I'm a huge fan of positive change. I know it's hard to convince others sometimes for change, but yes is the answer. I'm not currently working on any projects there, but I think just acknowledging that we have got stigma within our health service is the first part. All of that unconscious bias training is important because we all have unconscious bias. And then, I think the reason our project, as an example, worked so well is because it was co-designed, co-produced, not only with our team, which was the most important part, but with many community kind of organizations, community stakeholders. So remove that top-down decision. So if we're going to talk about stigma of mental health, we should be talking with patients living with mental health problems, severe mental illness. Likewise, prison populations. There's so much stigma, so many barriers, and it leads to huge issues around access, poorer health outcomes. We know people with severe mental illness die much younger than the rest of the population. So yes, I think there are parallels that can be drawn, and there's lots of work that I'd love to see happen in that space.
So Camille, in terms of this process, Lewisham was very fortunate to have you and public health investment and many others who worked with you, because it makes a lot of difference and the residents benefited, and I'm so pleased they did. Not everywhere do they have that level of either the opportunity or the space, because as you said, if you invest, you're not investing in a project, you're investing in developing the leadership. That's what they did by having someone with your passion come out, because it's the leadership that makes the difference of lead. I mean, many people were giving their personal time for these projects, and you kind of sit back, think, so it's the leadership that drives, not the investment alone. What would you tell a GP practice or a PCN who say, we don't know where to start? What should we do to begin with? What will be our first few steps? How would you suggest they take this on?
I think that there are, it's very kind of you to say I'm passionate and all the rest, which I am. I know I am passionate, but I'm not the only passionate person out there. I know that for a fact, and I'm sure lots of the people on the call are also incredibly passionate and excellent leaders. So I do think the first thing is there's not much paid clinical leadership time. I mean, for other projects I've done, when I first qualified, I was able to find pockets of funding in things like SPIN fellowships. I don't think they exist anymore. In primary care, I think there are, every few years there's a different type of fellowship. So there are things like that, making those kind of pockets of funding more available. PCNs and practices could pay for clinicians' time if they were forward thinking. I hear probably people going, we can't afford that. And I do know that money and times are tight. I would like to see, as things change, as we move around integrated neighbourhood teams and maybe contracts are being reviewed, it would be lovely to see that built into contracts as well. But I think, PCNs can appoint leaders. There's often a health inequalities leader in primary care networks, but they're not always paid. So I do think having that paid time is hugely important, but also asking the salaried GPs, the partners, the GP trainees going through, but not just the GPs. We're talking the other healthcare professionals, the nurses, the healthcare coaches, everyone in primary care. There are so many passionate people who want to do something, and it's just creating that opportunity, which is hard, I hear you.
Yeah, I think I'm with you in this. I think there are practices where I have seen some rather sterling work happening by using QI and the students who are coming in there in a training practice, work with them to genuinely spend time to understand what the population demographics of the practice are. Because when you do the population health study, I mean, it's like the slides you started with when you started talking about really understanding what's the level of homelessness in Lewisham.
Yeah.
What are the challenges around that? What's the policy direction that's helping or inadvertently impacting it? But when you pull those stats out, it gives you a good starting point to understand what is the most vulnerable part of the population, and then how do you correlate that with your either your COAF outcomes or your health outcomes to really say, this is the group that is really missing out on good, equitable healthcare, which should be within their grasp, but isn't for whatever reason.
Yeah.
Whether it be language barriers, socioeconomic demographic barriers, stigma barriers, one just doesn't know. And I think you're spot on when you say about PCNs giving some thought if this is one of the priorities they need to think about.
Yeah.
But also at a practice level, probably spending some time to, when you started with the Marmot slides, to talk around What is our demographics? What does it tell us?
Yeah. I couldn't agree more. It's hard to design anything for a population if we don't understand and know that population. We are really lucky that we have an excellent population health management team in Lewisham, who were able to create dashboards for us to really look, okay, if I look at SMI or if I look at this age, what does that look like? Where does it actually come up on the map? We were so privileged to have that kind of tool. But most practices have got PPGs. Why can't we utilize those PPGs? Why can't we ask them what's happening for you? Is there a reason that you can't use our phone booking system? What's the biggest barrier? I think a lot of time people get nervous about things like co-design. And when I first did co-design a few years ago, there was not much guidelines, and I'm a medic and I like to follow protocols and guidelines and steps, and there was none of that. And so it was just speaking with people and asking them to design with me. And it can sometimes feel like you're the face of the NHS and everything that's wrong with the NHS gets directed at you. But every time I've done it, and I've done it a few times, it's always been an incredibly positive experience. And what's been designed has always been much better than anything I would have come up with only on my own. So I think there are ways of kind of getting to know your demographic, even if you don't have these dashboards, by just speaking to your patients. And as I said before, I think a lot of people do know their demographics. It's just sometimes they don't have the time and they don't have the resource to do stuff like this.
So I think there are some comments about people pointing out to various ICBs to say, catch up, do it. And it's brilliant. It's brilliant to see how your passion has infected others to say, this matters. I think there's a really good comment from a colleague, and I don't know if they'd like them named, so I'm not going to name them, but I will quote the comment, which talks really nicely about, firstly, about your project being really inspiring. She says as outright, it's a really inspiring project. But more importantly, she goes on to talk about schools and young pupils and involving them and having that energy, zeal of the young influencers making a difference. And given the work you've done now with the Red Ribbon, yourself, and many other colleagues, I mean, you've spoken about 16 colleagues, organizations who are involved, which is just, it just snowballs into a movement.
Yeah.
Was there any thought? So how do you take it into the next generation by actually changing the habits of the population of how they behave to the health condition rather than trying to only make a change to the health condition?
I think yes, and I think this feeds very much into my other passion, which is lifestyle medicine and healthy small behavior changes. And again, why do we not co-design things with young populations? And when I did work with the Cancer Alliance, for example, one of our best campaigns around, I think it was cervical cancer, was done by influencers on TikTok because we met with people and that's the platform they were using. That's so anti-NHS, isn't it? Can you imagine well, some people probably are doing that, but it was transformative. The results we had from that was incredible. So yes, I think it is important to talk with young people, children, adolescents. I'm very far from being a child or an adolescent, unfortunately. So it's unrealistic for me to know what's important to them. I can guess, but it might not be right. So yes, I think, and hopefully if I come back in a couple of months and talk about lifestyle medicine, I can elaborate a little bit more on why I think that's important.
Oh, wonderful. And we're coming to the end of this. It's amazing how time flies when you're having fun. But let me pose one more question, a really good question. So there's a colleague who has posted a question around the challenge of getting engagement from wider people in a project. She's talking about running a project themselves, but is the traction from other health professionals has been a challenge. And we've all experienced it. People are busy. Even when it's a good stuff, people want to do it. It's not easy. It really isn't easy. I mean, I'll be honest, I've this passion of mine to run these webinars on my own free time, write a script, get it up and running, find the people who would make a difference, research this. It does take a lot out of you. And sometimes if you don't have the support for something wide enough like what you've done, you require a lot of support. How did you get that? Because that is really remarkable.
I think that I didn't always get it, to be honest. I think that you've hit the nail on the head. It's a huge issue. Um, so, I mean, ironically, in the primary care network, nationally, people are like, wow, this is great. But actually, the people in the primary care network probably least, the practices were least kind of up to date in what we were doing. They were least kind of, I don't want to be mean and say supportive because they were very busy, but yes, they were the least engaged, I would say. And that's for various reasons, including the fact that they are incredibly busy, overstretched, underfunded, and all the rest. And let's not ignore the politics, the internal politics we have within our health systems absolutely blows my mind. But yes, I think it is a real challenge. It can be really hard to get traction. I don't know if I have the answers, but what I would say are, I mean, it sounds so simple, but I think an example with this project would be when we first met and co-designed with Red Ribbon, myself and Joyce. Um, we sat down, we decided what we wanted to do together, and we left. And only later did they say, actually, I'm not happy with it. And there was a power imbalance, and it completely threw me because I thought we'd had a really excellent kind of chat and discussion. And it was taking that back down, stripping away the hierarchy, and really just being able to open up and talk freely. And I think it's the same kind of thing here. We're all just people and we're all just trying to do something for good. And so, yeah, where possible, just trying to have those open conversations of what you're trying to do, why it's important. If you really want traction, align it to all the targets that they have financial incentives. But it's a real challenge. I don't think I have the answers for you, I'm afraid.
I think, colleagues, you've heard it from Cami, who's done it. I think the thing I would say, having a few years, not always helpful, of experience of both losing and sometimes getting what you want, is recognizing when you truly believe in something, don't give up quickly. Please don't. It's difficult. It's not easy. And you don't know how many times one feels like, that's it, I'm going to pack it in. But you believe in the cause. And if you believe in a cause, lead it. Please lead it. Because each time one cause breaks through, which takes time, takes effort, you only need two other people to join you. And what's really interesting was a statistic I was presented by someone else the other day, that to create a movement, surprisingly, you only need 15% of people to be on your side. 15%, that low, and it's a movement. So I'm not going to name you because it's a fabulous question you've raised there. But I think it's really important to recognize what you're doing is phenomenal. And hats off to you. And one of my colleagues who said the monthly webinars are educational, and for us as volunteers, supports the public. Thank you, Jamu. I can name you. I've known you for so many years. I've known Jamu for almost 20 years of my life. She's one of these amazing people who is not just worked with me in many guises, but has also been, she started a PPGs, the practice, because there wasn't one, and we had run a webinar on PPGs, and
Wow.
she did it. And she's one of these leaders who doesn't recognize she's a real leader in so many ways. And thank you for that comment. I really appreciate that. I think if I may just say, Cami, it's always a pleasure when one sees a change that makes a difference to others. It's always a pleasure. But it's very special when one sees an evolution of a movement. And today, what I've heard from you was that transformation. It's just not the here and now, but what you spoke about was the tomorrow of healthcare, and you've changed that. And it has been such a joy listening to this. I mean, when I developed the webinar, I spend a lot of time coining what would we call it, and the future of primary care is the term I came up with years ago now. And today is one of these days when I felt I'm seeing the future of primary care, a difference happen. And it has been absolutely such a joy to have spoken to you. There are some phrases that I was trying to just make a note of as you were talking about inequity, and unfairness of how it can land. There was about stigma, and that really resonated because I work in mental health for so long, and stigma is it's just so easy. And even kids in playgrounds, they call each other you're mental, and you feel like saying there's no such term, there is no such word in English, for God's sake. But it just shows the prejudice that comes with society sometimes to just have a mental health condition. And then there was this thing about on your slide which says, I learned to remain humble. That was someone's quote on the slide, which I really loved, because it's so easy to fall into the trap of, oh, I'm the giver. But we are not. We are all in this together and learning this together to get it right, because it's complex, it's difficult. And your community health hub work, mind-blowing. Absolutely mind-blowing. Camille, I can't thank you enough, because it was just the most wonderful insight into what you are looking to create in Lewisham and what you're leading on and your colleagues are working on, which is just brilliant. And I am very grateful for the time you've given us today. And thank you so much. It has been such a joy. I think there are a few other thanks also I'd like to record before we conclude today. It is to each and everyone. I mean, 200 of you registering for a webinar is no joke. And we've consistently maintained a number like that. We are on so many platforms. Last month, we had about 300 people on different platforms when we counted them out later. And this is just on the webinar, because then these are released and people then rewatch them, those who couldn't watch them, and we try and do a count somewhere in a few months' time. I'm blown away, and thank you for the support, because that's what makes it so worthwhile, that people find it helpful. People find that difference makes all the difference here. And the personal time I give in becomes meaningful. So I'm very grateful to each of you for being with us. We have become a family in some ways. The two people in the background who almost always switch off their camera 2 minutes before you all come in. And Candice and Harry, a big thank you. But for you, this wouldn't work like clockwork. I mean, I try and make it look like I'm in control. I promise you all, kid me not, I have no clue about digital stuff. It is they who keep me on the right and honorable here, and we make it happen. Candice or Harry will put in the chat something around a QR code for you to put your comments so that we can have some feedback. Like clockwork, I told you they will start doing something, and there it is. There's a QR code for people to give some feedback to us so that we can continue to make these webinars work for all of us and continue to focus on that. Please do give us your feedback. It is really helpful and meaningful. And please join us again